Welcome to Heaven and Health Podcast, your trusted source for insightful conversations on health and real estate talks. I'm your host, Angel Polido. If this is the first time joining us, Heaven and Health Podcasts are designed to inform the public about different health matters and to give you an insight about anything concerning the land. Joining me in our today's episode is Dr. Chipewa from Queen Elizabeth, who will be giving us an insight on diabetes. So stay there, relax, and stay tuned. Welcome, Doctor.
Thank you very much.
So, in short, mind if you tell us about yourself?
I am Dr. Pascal Chipewa, and I'm working with Queen Elizabeth Central Hospital.
Thank you. So, focusing on our today's topic about diabetes, what is it all about?
So, diabetes, these are a group of disorders which are characterized by hyperglycemia. So I'm going to break down what hyperglycemia is. It is high sugars, higher blood sugars. So the group of disorders or conditions that are marked with or characterized by high sugars in the blood are what we call diabetes. And
so as long as you have high levels of sugar, that means you have diabetes.
So it has to be chronic. It has to be chronic high sugars. The high sugars don't have to be at one point in time, but there has to be a prolonged time where you are found with high sugars.
So what are the most causes of diabetes?
Alright, so this group of disorders are categorized into two. We've got type 1 and type 2 diabetes. So type 1, it's where a person has, sometimes you've got what are called autoimmune diseases. These are diseases that they tend to destroy. So there's some cells which tend to destroy your own cells, your own body cells.
Yep.
So they actually lead to type 1. So in type 1...
Okay, so these cells, do they come from your body or they are produced by other things?
So they actually come from your body. So your body have what are called auto-antibodies. They're like soldiers.
Yeah.
So soldiers that tend to protect you. So sometimes these soldiers, when they actually fight your own body cells, wrongly fight your own body cells.
Instead of fighting other diseases.
Okay, they do fight other diseases, but sometimes they fight your own body cells.
Yeah.
So here, for type 1 diabetes, these soldiers, they fight some of the cells that are in the what an organ which we call the pancreas. So they go there and destroy beta cells in the pancreas. So those beta cells are the ones that produce an enzyme what we call insulin.
Yeah.
So that enzyme is like a key. So it will open body cells for glucose, which is a blood sugar, to enter in your body cells from the bloodstream to your body cells. Now, when those beta cells from the pancreas are destroyed by your own body cells, that means that key called insulin is no longer produced.
Yeah.
So when that key is no longer produced, blood sugars or glucose, they may be in your blood, but they cannot enter your body cells. So that is how type 1 comes about.
And type 2?
And type 2, so type 2 is mostly genetic and environmental. So it might be that in your family line, there are people who ever had diabetes, and also because of some lifestyles, for example, sedentary lifestyle and obesity, these can predispose you to type 2. So in type 2, sometimes you've got insulin which is produced, which is not effective, which does not work well on the cells, because there's sometimes there's kind of resistance to that kind of insulin. Yeah. So you might have relative deficiency of insulin, but in type 1, you've completely no insulin which is being produced.
So is gestation diabetes ladder, which is known like leading to autoimmune diabetes in adults, and MODY, which is also known as maturity onset diabetes, under type A and type 2, or there are other types of diabetes?
those are other types of diabetes. So the main ones are, like I've told you, type 1 and type 2.
Yeah.
But mode and ladder and gestation, those are just some of other types of diabetes which are not as common, but actually happens depending on scenarios. For example, the gestational diabetes actually happens in women that are pregnant. Yeah. So, but the main ones are type 1, type 2.
So these are the most, these are the most current diabetes that occurs in Malawi.
They are the main, types of diabetes that happens in Malawi and of course across the world.
Country.
Yeah, they are the main ones.
So what are the some symptoms and signs that the person suffering from diabetes shows?
So if you're suffering from diabetes, you're going to have the first one. You may have what is called polyuria. You pass a lot of urine so frequent. One. The second thing is what is called polydipsia. So you've got a lot of thirst, increased thirst. You just want to drink more. So you drink more and you pass urine a lot more. And you've got what is called polyphagia. Polyphagia, they want to eat more because the body cells, they feel like you're hungry. I've told you what happens that, the key, which we call it is insulin, is no longer there to allow glucose to enter from the blood to the cells. So the body feels like I'm hungry. It's hungry. And then you want to eat more, so you eat more. And you also tend to have to lose a lot of weight, which is not explained. So there's a lot of loss of weight. And intentional loss of weight, and those things, polyuria, polydipsia, and polyphagia, they will actually point you to have diabetes.
But it's normally that when you drink a lot of water, you pass a lot of urine. So how do you differentiate between these two?
So it is normal that when you drink a lot of water, you eventually pass more urine. But now in this scenario, you abnormally have increased, the thirst is increased. It's not just a normal thirst that we tend to have. So in a day, you would actually want to drink more, a lot more, and you'd actually pass more urine, a lot more in a day than how you would drink, and than how you would also pass the urine on a normal day. Yeah, and plus also the other symptoms have to be there, like the weight loss, for example, and the polyphagia. Yeah.
So does diet also contribute to diabetes?
It does. So diet does. So like I told you about obesity. So there are people who eat more fatty foods and more of the junk foods and tend to be obese. So when you're obese, you actually put yourself at a higher risk, of getting diabetes. Now, when we diagnose you to say you've got diabetes, especially this type 2, and it actually happens in other people, like from 40 years and above. What's type 1 will actually happen in younger people, 20 years and below. So diet contributes mostly to those that are old aged, like the 40 and above with type 2. The foods that will make you have obesity. But now when we actually find you to say you've got diabetes, we one of the things that we prescribe is a diet modification. We make sure that you control your diet so that sugars are not persistently high, because that might kill a person. We also make sure that you eat foods that have got vegetables, that there's fiber, in it, and we make sure that you reduce foods that have got a lot of fat content in them.
So does that mean that fat people are more exposed to diabetes?
So if you are obese, obesity is a high risk for type 2 diabetes. Yes, it's like
as long as you're obese.
If you're obese, yes, you are at risk of getting type 2 diabetes. And like I've told you, it's not only obesity, there are also some things that are related to type 2 diabetes. So it would be that maybe in your family, someone ever also had suffered from diabetes. We call them relatives. For example, maybe if your dad also had diabetes, if your mom or your sister or anyone, your uncle.
So it also passes through genetics?
It does. Genetically, yes. Genetically, there's an influence. It's one of the factors. So if there's a genetic influence and also you are obese, you're actually at the high risk of developing type 2 diabetes.
So what are the complications of diabetes?
All right. So the complications, we group them medically. We group them into microvascular and macrovascular. Now, so these are medical terms. But yeah, so we've got complications like you tend to have problems with your eyes, what we call diabetic retinopathy. So you may not see properly and eventually develop into blindness. So that's a diabetic retinopathy.
And it's under
It's under microvascular. You may also tend to have diabetic nephropathy, problems with your kidneys. So that your kidneys eventually might have got kidney injury, but you might have problems with your kidneys eventually because of diabetes. Also, your nerves might get affected. What do we call it? Neuropathy. Neuropathy. So peripheral neuropathy, kidney disease, acute kidney injury, and diabetic. What we call diabetic nephropathy. The other one is diabetic neuropathy, and then the one I explained earlier is diabetic retinopathy with the eyes. Those are micro. Also for the macrovascular, strokes actually can eventually result from even diabetes. So a person can eventually get a stroke. We call it it's a cerebrovascular accident. Sometimes also
where like the body, some other parts may not be acting normally.
No. So some of the vessels that actually lands in your brain, but actually at some point they may rupture. So they may rupture. Or there may be a clotting. So that is quite a hemorrhagic stroke. Or there may be a clotting. Those sugar cells can actually build up and then clot and block the supply of the blood to other brain cells, and that is also called ischemic stroke. So that also is that in it. So stroke and also coronary heart disease. So in the heart, there are some of the vessels that actually feed your heart. So they may actually also be a buildup of sugar levels and then eventually broke the supply of the blood. And there's what is also called peripheral artery disease. So we've been seeing a lot of peripheral artery disease where the vasculation or the supply of blood to the limbs, your legs may not be efficient, and eventually we cut out of legs when we cut out of legs when that is when things reach those levels. Sure. So those are some of the complications that may arise from diabetes.
So does diabetes intersect with other diseases such as HIV and malaria?
No. So intersecting, you mean occurring, or maybe diabetes causing malaria, or causing HIV, or HIV
causing some other complications? It might either cause other diseases or sometimes cause other complications.
Yes. So diabetes may not necessarily cause diseases like malaria, for example. Because malaria, it's how it's caused. We've got mosquitoes. Anopheles mosquito biting and what is called falciparum, Plasmodium falciparum being transmitted. So it's that which causes malaria. But yeah, so due to the complications, some diseases and HIV may not be caused by this, but due to the complications, some diseases eventually might arise. Like what I've told you, that you may have a stroke. Stroke it's a full disease on its own, but it's actually coming as a complication of diabetes.
Yeah.
We just talked about diabetic retinopathy. You might have actually now diseases with the eyes. That's a full, it's a full spectrum of diseases occurring to you. Just talked about, diabetic nephropathy. You might have actually kidney disease, and those are big diseases, which might actually kill a person, and they would actually be resulting from diabetes. So yes, there's an actual intersection of the diseases, and I talked to you about the peripheral artery diseases, where ischemic limbs happen, and so those are full, spectrum of diseases which can kill a person. But yes, they're coming from diabetes. Sure.
So what type of procedures and tests do you take to know that someone has diabetes, and what kind of procedures do you undergo to know that the medications are really working?
Great. Yeah, so we would tests that we are doing at first presentation. So so hyperglycemic test to say, are you diabetic? So we do what is called a random blood glucose. So we want to check the levels of glucose that are in your cells. So we've got we use a glucometer, and then we take blood and we learn it. And if sugars are higher than 200 milligrams per deciliter, then we say you have you've got high sugars, you are hyperglycemic. So it means you've got a lot of sugar in your blood cells. So we use RBG, random blood glucose, is one of the hyperglycemic tests. One of other tests that would actually tell us about your levels of sugar, we call it oral glucose tolerance test. So we want to measure the glucose that is in your plasma, and when you've eaten. So when you eat, for example, give you food, and then 2 hours later want to see how is your sugars going. Is your sugars being able to be taken into the bloodstream? So how are you tolerating the glucose? So we do that. It's an oral test, oral glucose test. Mostly we do this also when we actually following up the patients. So oral glucose test. And another test that we do when you're actually following up the patient to see if they have actually been faithful, because you may not have been faithful taking your medications or taking insulin, and then you come today in the hospital and you've taken the medication, you've taken insulin, it actually show that you've got low sugars, but then we want to see, have you actually been faithful? So we use actually what we call hemoglobin A1C or HbA1c. So this actually tells us how your glucose levels have been in the last 8 to 12 weeks. So for the past 3 months, it actually tells us how you've been taking your glucose. To say,
so the medications you mean, like, you follow the medications after 2 to 3 months, or?
No, we follow up these patients in the clinic, maybe monthly. So monthly we tend to follow up with them. But yeah, so when we actually do the hemoglobin A1c test, it will actually tell us how you've been taking your medications, or how glucose has been actually being controlled for the past 3 months. So we actually have a picture that, even though at presentation here to the hospital you seem to have low sugars, but you haven't been taking these medications. So that is one of the tests that we actually use, but in the follow-up. So sometimes at presentation they may present in what we call diabetic ketoacidosis in DKI. It's actually a diagnosis that we make. So it's a whole lot of stuff, but yeah. So when they have presented in that manner, we also check their glucose. We also check their urine to see if there are ketones. So what happens in your cells, in your body cells, when they sense that we don't have glucose here, because glucose is the blood and can't be transported there, it breaks down the fats, ketogenesis, and then we've got ketones. So those actually go to your kidneys, and then you get excreted in the urine. So we also test your urine to see if it has got ketones. And also we take what is we call the blood gas. We take your blood either arterial or arterial venous, and then we do a blood gas to assess the pH, to say is your blood acidic or basic. So in these patients, when they have presented with DKA, it tends to be acidic.
What if it shows neutral?
Then actually we also assess. So clinically, if your blood sugars are high and you've got ketones, and then it's actually showing maybe 7, which is mostly unusual. But we know what the patients do not read the books. It's most unusual. But still, because of that whole picture, we will still be able to treat you as somebody who is in DKA with diabetic versus with diabetes. So we do that. But also one of the tests that we would actually be doing in these patients in the follow-up. In the follow-up, we want to monitor the complications. So in the follow-up, we actually do what's called fundoscopy. We want to check how your eyes are functioning each and every time you present in a clinic, which is in the month. In the month, they also want to assess your heart. So we tend to send you for chest X-ray and for echocardiogram, just to also be monitoring your heart. We also send them for kidney function test, renal function test. We want to know how is your creatinine and how is your urea. So those creatinine and urea, they are going to tell us how your kidneys are functioning. So if we see that these are abnormally high or these are abnormal, then we will know that your kidneys, there's a complication. Your kidneys are not functioning very well. And so we tend to also assess those tests.
What about those who are suffering from gestational diabetes, especially in women? What kind of tests do you learn?
All right. So in women, we will do the usual random blood glucose. We want to see how are their sugars. Are they abnormally high? So if they're abnormally high and then they're pregnant, and we also ask if they have ever suffered from diabetes. So if the woman already had diabetes and is also having diabetes, we say maybe, but we know you are a person who is already diabetic. But there are people who have never in their life suffered from diabetes. And they only suffer diabetes within the period of pregnancy. You say this is gestational diabetes. So we would also want to understand those levels. Is this high levels of sugars, are they happening only in this pregnancy period, or they have actually been there before the pregnancy? And normally those with gestational diabetes, they tend to resolve even after pregnancy. When the pregnancy ends, then
the diabetes also ends.
Yes, the diabetes ends. Yeah.
So what are the most treatments that you offer to patients who are under diabetes? Great.
So for example, those that are type 1, I told you in type 1 diabetes, you actually don't have insulin. You absolutely don't have any insulin. So we give them insulin, which is synthetic, which is made from it's a synthetic, it's man-made. So we give you insulin, and that insulin acts like a key. So to open, where the original insulin which is produced in the body is not being produced, so we give you that one, and it opens so that blood sugars can actually go in your body cells. So administration of insulin. For type 2, there are drugs like metformin and glibenclamide. So we also prescribe those drugs, especially for type 2 diabetes. And also we also advise patients to actually be doing exercises. Like I told you that they must be exercising. We also advise them on diet modification to prioritize taking a diet which has got more fiber in them, about vegetables, and also to modify that. When you have diabetes, you don't have just to be eating like any person, because when you eat a lot, sugars might actually rise, and you might actually get into a coma or something when sugars are too high. So we also modify their diet to say, eat this amount of food, and we also advise them, because sometimes they may tend to be hypoglycemic if they need some more insulin and haven't eaten. They may tend to be hypoglycemic. So we advise them to be having sweets sometimes when they feel dizzy. They need to be taking them. So there's a full concept on management, how we manage them.
So normally a person who is under diabetes treatments, how long does it take for that person to heal?
For insulin, they take insulin for life. They take insulin for life, and so is with glibenclamide. And for type 2, where they take metformin and glibenclamide. Of course, when we see that there's with type 2, sometimes we may taper down. Taper down is to reduce. Sometimes we may actually stop them. But normally, this insulin, that they take this medication for life, and so it's also metformin and glibenclamide. Because, like I told you in the first place, for type 1, they completely don't have insulin.
Yeah.
So when you stop giving them insulin, then they will die. And so you tend to give this for life, because our insulin is in us for life.
Yeah.
So we want to support them lifelong. Sure.
Are there any other technological and advanced treatments so far?
So far, no, not really. Insulin works wonders. It does work wonders, and so is drugs like metformin and glibenclamide. So right now, at a place like here at Queens, those are the drugs we rely most.
Yeah.
And even for the patients that we see, we usually give them those kind of medications.
Have you ever come across any other any strict challenges when providing your medications to patients?
Not really, but sometimes the problems that we tend to have is on the part of patients themselves is compliance, adherence. So these are the type of the drugs that you need to be taking throughout. Sometimes, of course, we see, but these are drugs that, like insulin, you ought to be just taking. So sometimes, patients are just tired.
Yeah.
And they don't take insulin, and then they come here in a coma, what we call diabetic ketoacidosis, and I may just simply because they are not taking insulin, or sometimes, when they're type 2, and then they tend to be bored taking drugs like metformin and glibenclamide, and then they come, in an emergency situation where the sugars are just too high. So those are the things. The problem is usually compliance, and sometimes, like sometimes when they're not being taught properly on managing things like hypoglycemia, for example. You are diabetic, you haven't eaten, and you take insulin. So the small sugar that was remaining in your blood, that one, it gets in the cells, and then you may actually have reduced sugars in your bloodstream, and that on its own is a problem. A person can die. We call that hypoglycemia. So those things, when they're not well taught, then we've got all those things happening to these patients.
So it means that when you have low blood sugars, you may lead to
actually you can. That's also, you can die. When you need to have normal sugars in your body. You don't have to have too low.
Do you have a normal range of sugar levels in the body?
We do have. So it's from 70 to 126 milligrams per deciliter.
Above that means you.
Above that, so it's problems.
And below 70 as well.
Especially when it's below 50. If it's below 50, that is actually a problem. We need to we supplement you with some sugar, which we have.
So what kind of advices can you give to people who are seeking maybe medical treatments, but they are failing to go to the hospital? So in case they just want to use some locally available resources so that they could be treated.
Great. So that's a huge problem we have in a setup like Malawi, where most people are most used to traditional medicines. And this is not only traditional medicines like what we call Asinyanga in the rural setup, but even in urban settings, we've got herbal medicines being sold. And others say this herbal medicine will treat diabetes, it will treat hypertension, it will treat heart failure, it will treat no, we don't have such kind of medications which have that working capacity that they can heal so many diseases at once. No.
So, I wasn't referring to something that is going to heal them, but something that may help them while they are preparing to go to the hospital.
All right.
Yeah.
But for these kind of patients, I would strongly advise that they seek medical attention as quickly as possible.
Yeah.
Because when they come here we give them the necessary counsel that they need to be doing when they are feeling symptoms, and also we give them the medications. So for example, if you are diabetic and then you are type 1, you cannot do without insulin. Even at home you cannot do without insulin. There's nothing you can do other than insulin. So these people, they need to be coming to the hospital so that they get insulin. Those that are type 2, they actually need to be given metformin and chipewa. So these are diseases that first aid, like be there and do some 2-3 things may not necessarily work, but they need to come to the hospital. So that's the advice. They need to seek medical attention as quickly as possible.
Before we conclude everything, do you have any remarks?
My remarks is just to say that people need to comply to medications. If they know that they have got diabetes and have been come to the hospital, please comply to your medications.
Yes.
And they need to, if they are also, mostly we follow up these patients in the hospital, they need to be coming to the hospital to be followed up. Because if they don't comply to the medication, then they tend to develop complications, which we've discussed here. And if they do not come to here also for follow-up, sometimes they may, present at a stage which things have gone extremely wrong. So I would advise them to be compliant and to become to the hospital for follow-up. Sure.
Thank you very much.
Thank you very much. You're welcome.
Thank you very much for being there with us, and this is how Dr. Pasco has displayed and given us an insight on diabetes. Be there until next time.